This is totally different from the courses I've experienced before. It is quite an experience.
Everybody in the injector group is really experienced, and you really learn a lot, not only from the trainer, but also from each other.
I want to be the best. So I want to learn from the best to be the best.
It's not the simple, I show something, you do it. It's really like a discussion between specialists.
I can definitely say I would recommend this course because every time you see something new and you can develop all the time. So never stop learning.
That is right. Never stop learning, because knowledge is beautiful. Welcome. Welcome to the evolving field of regenerative aesthetics. This is a special live stream that we decided to organize for you, people who are curious to know more about this really exciting, evolving field of regenerative aesthetics. Let me start by introducing myself. My name is Yanni van Lochem. I'm an aesthetic physician from Amsterdam, Netherlands. And we are broadcasting live from UMA Academy headquarters. And I just want to say welcome to the world of UMA. I'm the founder of UMA, and I have created this educational institution based on my experience in the creation of a medical specialty. Because in the Netherlands, as you can see behind my title, Aesthetic Physician KNMG, in the Netherlands, we are the first country that has an official registration of the medical specialty aesthetic medicine. And I had my PhD also in the field of aesthetic medicine. And besides medicine, I studied also medical biology, and I have a Master of Science in medical biology. So I'm also a biologist by university training. So these are some of the books that I've published. And the latest one is this one, Calcium Hydroxylapatite, Soft Tissue Fillers, Expert Treatment Techniques. And this is the second edition. The first edition was a great success, and that's why they asked me to publish a second edition. Again, a lot of work. And in the end, this has been one of the reasons that you probably know me, because I've been working with calcium hydroxylapatite a lot since 2005, and actually also with PLLA since 2006. So for me, biostimulators have always been a part of what I offer to my patients. And that is what I always tell my colleagues. Get your patients noticed, not your work. And that has been something that I have been doing since the early 2000s. And for a long time, a lot of people in our field have been injecting hyaluronic acid only because they somehow were afraid of biostimulatory products because they are non-reversible. But something changed along the way, and now we find ourselves in an era of regenerative aesthetics. So it all began, actually, there was a shift, there was a tipping point in 2023 when the British Association of Aesthetic Plastic Surgeons in the UK reported a 26% decline in filler injections in just 1 year. And in that same year, and I also noticed it in my clinic, people were starting to ask their doctors, we've injected all this hyaluronic acid, but can we remove it and start again? So for the first time, patients started asking, can we start over? And of course, it was because of all these posts that we saw on social media. Facial overfilled syndrome was a crisis for our industry. At least for some people, it seemed like a crisis. People were getting tired of hyaluronic acid treatment because they saw these overfilled faces. But I think filler fatigue was not really a problem. It was a message from our patients. And that message was probably one of the most important signals that our field has received over a decade. Because we have all seen the shift, where before 2023, our patients wanted to look sculpted, defined, almost artificial, as long as it looks good on Instagram. But all of a sudden, people started to want more of the authentic face. And so, if you think about this new patient right now that rejects the constructed face and embraces the authentic face, that is not a patient that rejects aesthetic medicine at all. No, they just reject a certain philosophy of regenerative aesthetics. They just don't want to look fake, right? They want to look real, dynamic, and alive. And so there's a difference between these two patients. And also that means that for us as physicians, as people that apply these products to our patients, we have to have a different conversation with these patients. Because first, they asked, how do I look? But now they stopped asking, how do I look? And they start asking, how do I age? And these are two fundamentally different questions. The first question, how do I look, is a cosmetic question. You answer it with volume, with correction. This question, how do I age? That's a biological question. And you answer it with cells, with tissue, with science. And more people are asking that second question. And you probably have noticed this already, because the answer to the second question is, of course, regenerative aesthetics, where we are moving away from hyaluronic acid only and incorporating other modalities like biostimulatory products and other modalities that I will discuss today into our practice. Because hyaluronic acid replaces, while biostimulatory products restore, right? And this is truly a very significant difference between these two, because hyaluronic acid, and don't get me wrong, I love hyaluronic acid, and even though there may be a market shift where the demand for hyaluronic acid decreases and there's even patients that refuse hyaluronic acid, all right, but hyaluronic acid has been the reason that we are all in this business. They're the reason that we have been able to give these patients back their confidence, right? So we have to keep on loving hyaluronic acid and keep on offering hyaluronic acid. But in addition to hyaluronic acid, we can help our patients achieve that natural look with restoration of tissue, with rejuvenation on a cellular and tissue level. So where hyaluronic acid gives us the possibility of the before and after picture, where the after picture, the patient looks younger, biostimulatory products give us a before and after under the microscope, where we see tissue that actually looks like we have been injecting a rejuvenation strategy to our patient's tissue. And that's not a subtle difference. And of course, that has an effect on what we talk about in the treatment room. We have to actually explain to our patients that we're going to be doing all these treatments to, and maybe they're going to be painful. Maybe they're going to cost a lot of money. And maybe they're not going to see anything. But until a few months or a few weeks later. So people have to be invested in the process. They have to believe. They have to be convinced by the science behind what we offer. So what does this patient look like? What is the regenerative patient profile? Well, she may be reading ingredient labels. She may be a person that intermittent fasts. She may be wearing like a wearable like I'm doing that measures your oxygenation and your heartbeat and your sleep cycles. She may be the one that really dives into the science herself. And that is the sort of patient that really needs a proper explanation. So we need to know what we are talking about. And that means we are doctors, and so we are students for life, because it forces us to read up on the literature, to maybe watch webinars like this one, or maybe go to conferences and really listen to what the presenters are saying about cell biology, biochemistry, and all that real scientific stuff that we may have heard in medical school for the last time, but this is really important as a basis of regenerative treatments that we offer. Right? So, in the end, fillers have given aesthetics to the world. The regenerative era will give aesthetics a future. And that's why it's really important for us to know about what kind of regenerative and biostimulatory products we have, what's available for us. So I'm going to start with products that you can buy from companies. I'm going to start with PLLA and KAHA. All right. And after that, I'm going to introduce a new product that can be used as an autologous regenerative modality, the ExoSmart system. But this is after KAHA and PLLA. So what do they have in common? KAHA and PLLA? Actually a lot, because the primary cell that's the target of these two biostimulatory modalities is, of course, the fibroblast. And many of us know that besides the fibroblast, there's actually more cell types that also get influenced by these products. And it's quite an interesting observation to see where the fibroblasts are. Of course, we know that the main cell of the skin is the fibroblast. But fibroblasts occur everywhere in the body. And this little video shows that very nicely. You see all this connective tissue. This is actually collagenous tissue. And collagenous tissue is, of course, made by fibroblasts, right? Because fibroblasts are the cells that produce collagen. And you see everywhere, you see little blood vessels everywhere, and you see beautiful collagenous structures. So if you think about where collagen is, it is actually also in the fat tissue, because the fat, the subcutaneous fat and the deep fat is organized and it's compartmentalized. And of course, in between the fat, there's all this connective tissue, all this collagen, and all these fibroblasts live there. Actually, if you really count the amount of adipocytes in fat and you count the amount of fibroblasts in fat, you will see that there are more fibroblasts per volume of fat than there are actually adipocytes, because fibroblasts are much smaller than adipocytes. This is an interesting little video where you see this, and this is in a tendon, a very, very strong and thick collagenous structure, right? A tendon. And you can see the fibroblast moving through the tendon. So even though this is very thick and hard tissue, you can see that fibroblasts are still very capable of migrating and moving through a three-dimensional collagenous structure that is very stiff. So that makes us realize that not only the skin, but also other collagenous structures in the face are a potential target in facial rejuvenation and regenerative aesthetics. And so these are potential targets for our regenerative modalities. So if you think about that, most people inject PLLA and KAHA at the dermal subdermal junction. Cannula technique, superficial, maybe diluted, for skin quality improvement, for tightening of the tissue. But actually, if you look at this anatomical image of the retaining ligaments and the septae, you start to understand that there's actually much more that we could potentially stimulate. Now, if you think about the whole field of regenerative aesthetics and actually the science behind it, right? We only have 1 hour for this webinar and I want to cover a lot, so I'm going to be a bit brief. But there's basically 3 key pillars in regenerative aesthetics. First, there are cells. Here you can see fibroblasts, right? So the fibroblasts are the primary target. Of course, there's also other cells that can be targeted, like keratinocytes. There's actually endothelial cells for vascularization, and there's even adipocytes that can be targeted. But the primary target is the fibroblast. And you can see in this image that the fibroblast is in stretch mode. That means activated. It's activated because of the scaffold. And the scaffold in this image are collagen fibers. Long, strong, young collagen fibers. But if you compare that to 80 plus skin, and that skin is aged, there's been UV every summer, the collagen fibers are going to be fragmented. They're not going to be as good as a regenerative scaffold for these cells to adhere to with their integrin molecules. And that means that these cells, they cannot be activated like the cells that do have a scaffold, right? So regenerative scaffolds are really, really important for a regenerative effect. Something three-dimensional, something mechanical for these fibroblasts to attach to. Now, the interesting thing about PLLA and CAHA is that as they are particle-based products, they have microspheres or particles, they function as a scaffold for fibroblast adhesion. Right? There's more to it. I know it's much more complex than this, but this is one of the key ingredients of regenerative aesthetic pillars. The third one, BioCues. And of course, I've chosen an image here with some exosomes because we're also going to be talking about the ExoSmart today. So the exosomes are actually an example of a BioCue, but of course there's also growth factors and other signaling molecules that can serve as an activation that actually can stimulate these cells as well. So right now, I'm going to dive a little bit deeper into PLLA because PLLA is such a magnificent product. Actually, I've been using it since 2006. And at first, when you start PLLA, it was a little bit difficult because you inject something, the patient looks great, but then the water moves away, the microsphere or the particles remain, and then you have to wait and you have to hope that the collagen buildup is going to make your patient happy, right? So this has been a journey for me and also for my patients where you gain the confidence. You gain the confidence because you start to know the product and you don't feel like you're actually selling something. No, you're actually explaining something really works. It's science-backed, right? Because some products, some PLLA products like this one here, this is Lassin Pro, for example. These are like more microsphere-like particles. They're more rounded. But also the less rounded particles, they can serve as a biostimulatory scaffold for the fibroblasts to attach to. What is interesting about PLLA is that when you put it in water or in tissue, then it hydrolyzes. It means it dissolves. So with water, it splits into small single lactic acid molecules, right? So the interesting thing about PLLA is that this molecule alone is a regenerative BioCue. So that molecule has specific receptors in many cell types, including fibroblasts. The GPR receptors in very, very, very cell types, and that has an intracellular effect on the activity of these fibroblasts. Also, it can bind to lactylation molecules, and thereby it has an epigenetic effect because the histions can have a specific effect on which kind of genes are going to be expressed and what other genes are going to be suppressed. And of course, it has a paracrine immune stimulation where macrophages are stimulated to differentiate into the anti-inflammatory M2 type versus the M1 type. And with some PLLA products, maybe initially there's an M1 reaction, but I believe that after hydrolysis, because of the M2 skewing, that also becomes a regenerative field, right? So normally we inject PLLA in such a way. Superficial subcutaneous injection, where we use the product usually with a cannula, and we inject it subcutaneously. And you can see that from this beautiful single entry point, I like to call it the stellar technique, we can advance this product up to the temple. We can go down subcutaneously and create this kind of like a star-shaped pattern with the cannula. And this is really something that gives our patient that really specific glow in their skin, that healthy glow that people really love so much. So in this example, I use 3 entry points, but actually it doesn't matter. It doesn't matter where you put your entry points, if you put it at the mandibular angle or anywhere else in the cheek, as long as you give a nice and thin little layer just below the skin in the superficial subcutaneous fat, then you can have a beautiful, let's say, stimulation of the dermal fibroblasts, but not just the dermal fibroblasts, also the fibroblasts in the subcutaneous tissue, the hypodermal fibroblast, because these are going to tighten the superficial fat along with the skin stimulation. But now that we know that there's not just fibroblasts in the skin, we can also think about where else can we inject PLLA? Where else can we do this? And you see the pink over here. That is where I inject PLLA at the dermal-subdermal junction, subcutaneously. You can see that it's also being used for stimulation of hair growth. It can be used for skin quality improvement of the forehead, of the temple, as you just saw, of the cheeks. But the blue depositions are the deep injections. And with the deep injections, I specifically go to the retaining ligaments and septae. Of course, when you inject PLLA, the collagen that's being formed, that does take some volume, right? So the volume that's created could also be used for patients for revolumization. For example, with deep temples, you can use PLLA for volumization of the temples. But I think it's very interesting to look at what you can do with PLLA. And now here in this example, I'm injecting PLLA and I'm stimulating the frontal septae, the superior, middle, and inferior frontal septum by creating injecting some PLLA on the periosteum there. And here I'm injecting in the superior temporal septum. So these collagenous structures, they are actually tightened and erected by injecting the PLLA. Now here's a superficial septum. This is the inferior temporal septum, where I'm advancing the cannula. You can see me pop through that resistance. Here also with the zygomatic retaining ligament, you can see me pop through that resistance, and then I'm injecting inside those ligaments, right? And also in the anterior cheek, this is the orbicularis retaining ligament. This is basically in the palpebromalar groove, orbicularis retaining ligament, zygomatico-cutaneous ligament. So these ligaments can easily be injected from that entry point. And this is the zygomatico-cutaneous ligament that actually can also be used for volumizing. So if you inject a lot of product in a deep medial cheek fat compartment, then you can volumize your patient. This is what you see after one treatment, 2 months apart. And this patient, you can see that, yeah, she does look a little bit better, but can you really put your finger on it? A little bit, right? You can see maybe that the forehead, the wrinkles are a little bit smoother because of all the collagen that's being formed in the subgaleal glide space, where it's gliding less, right? So the layer number 4 is a glide space, and it allows us to move our brows up and down. With collagen formation in there, there's going to be more restriction to the movement of the brows, like toxin, what we want to do when we inject toxin in the frontalis muscle. But this is more of a mechanical restriction on the mobility of the brows. But if you look at the Vectra image, you can see that all these little arrows, they all point up, you see? So there is a very subtle, but a very real lifting effect after PLLA injection in layer number 4 and targeting the retaining ligaments of the face. So with that, I hope I already maybe opened your eyes to new possibilities of injecting PLLA. Let's have a look at GAHA. Right? Maybe you've heard about the fact that there's already some evidence on the fact that CAHA actually functions as a regenerative scaffold, where histology images show that the fibroblasts are actually being attracted by the microsphere. And when they arrive and find themselves touching the microsphere, they hug the microsphere and they attach to the microsphere with their integrin molecules. So this is what we see. And we see that there's a lot of effect. There's collagen type 3, type 1, elastin production, proteoglycan production, and on blood vessels, it has an effect of angiogenesis. So there's an endothelial cell involvement as well. But this paper doesn't answer the question of how the fibroblasts know where to find the CAHA microsphere. Now, I recently published a paper, and this is kind of the, let's say, abstract of that paper, where you can see that CAHA is a regenerative scaffold, but it is also, when it is in the tissue, it starts to dissolve. The waste product is calcium and phosphate. Now, phosphate is kind of inert, but calcium is absolutely active biologically. And the interesting thing is that if you think about this microsphere dissolving, right, maybe with a little help of macrophages, then there is going to be more calcium in the area. And there's a gradient with a high concentration of calcium here and a lower concentration of calcium further away from the particle. Now, the interesting thing about fibroblasts is that they have a specific channel, a transmembrane protein, a channel, a pore, that is specifically made for calcium ions. And so when the calcium ions flux into the fibroblast, what the fibroblast does is it directs all the other TRP channels to the direction of higher calcium concentration, and it starts to move into the direction of the higher calcium concentration, a process called chemotaxis. And when the calcium fluxes in, it not only stays inside the cytoplasm, but it actually makes its way to the nucleus, where it has an effect on the transcription of genes. So, and also the differentiation. So the genes of collagen and elastin are being, of course, transcribed, but the fibroblast is also stimulated to divide itself. So more fibroblasts are going to be there in the area. And of course, this is the hypothesis that I published. It still needs to be completely confirmed by more, of course, researchers that are curious about how this stuff really works. Right? So in the end, you have activated fibroblasts, and more of them actually than you started with, plus you have myofibroblast differentiation. And that is actually quite an interesting thing, because myofibroblast, maybe you remember from medical school wound healing, that myofibroblasts have contractile capacity. And so with myofibroblasts, you can actually understand why CAHA, superficially injected in the cheek, for example, with this technique, has a lifting effect, a tightening effect, because of myofibroblast activity. So over here you can see the technique where I use a similar technique actually as with the PLLA. You can see this is diluted. Normally the CAHA is a product that comes in a syringe, pre-filled syringe, where it's CAHA in CMC, carboxymethyl cellulose. And with dilution, you can make it more liquid, because the CMC has a certain rheological properties and certain elasticity that is quite firm. But if you dilute it, you won't see any visible depositions in the skin, right? So this is an example of superficial CAHA. But as you know, you can use it for skin quality, but CAHA, non-diluted, you can also use it for fillers, replacing lost volume. And now recently, we're starting to understand more and more about the retaining ligaments. So these retaining ligaments have become serious targets, right? So this is the versatility of CAHA that I really enjoy. And you can see here that I'm using very safe technique. Well, safe, of course, is an exaggeration. There's no such thing. A safer technique by really thinking about how much volume I inject per retrograde linear thread. Here I'm in the interfascial space. Here I'm subcutaneous. All targeting retaining ligaments over here superficially. You see the resistance, pop through it. Also here, normal cheek augmentation, volumizing. And we can also use it for popping through retaining ligament, lifting the zygomatico-cutaneous ligament, and injecting a little bolus there, and injecting actually also through the ligament. Right? The ligaments are something you can pop your cannula inside of. Right? It's not like a tree that you can't enter into. So this is the palpebromalar groove where I'm stimulating the orbicularis retaining ligament as well as the zygomatico-cutaneous ligament. You can even go into the tear trough as long as you stay on the periosteum. Most people use it for mandibular angle, with a needle, or maybe using it with a cannula, subcutaneous for contouring and making a better definition of that mandibular angle. Right. So that is what you can do with Caja. And the nice thing about this product is that if you use it on an annual basis, then you can have magnificent results like this. The before picture is 10 years before the after picture, right? So in the after picture, she's 10 years older. But of course, this is annual Caja and a little bit of HA and a little bit of toxin. But look, she looks younger, even after having aged 10 years after that. So that's the true power of biostimulatory products. And the more that we understand about these products, the more precise we can apply them. And right now, we are finding ourselves in the middle of a revolution in aesthetic medicine. We are finding ourselves in the inception point where longevity medicine is also getting more involved, right? So where aesthetic medicine and longevity medicine meet each other, this is the field of regenerative aesthetics. Now, I put the QR code here because Dr. Nicola Conlon, she has given a very nice take on longevity medicine and how it can be introduced into the field of aesthetics. And that also is a little bridge to something that I already announced that I'm going to present today, and that is the ExoSmart system. Autologous secretome, concentrated and activated. This is a CE MDR Class 2A device. It has been approved in many, many countries, including Europe. And today, I'm not going to dive deep into the science, but I'm going to dive into clinical application, right? You will hear much more about this product because it probably is a product that is going to be more interesting than even old school PRP, PRF, but also other devices that are medical device, well, actually cosmetic products of non-human or non-autologous origin that are being injected into patients, and there's quite a illogic to that. So what is this? So you can see 4 steps. The first step is to take blood from your patient. The second step is to make PRP and PPP, right? Actually, you know what that means? It means you draw blood, you centrifuge, you throw away the red and the white blood cells, and the rest you keep, the plasma, basically. Then you put it into the ExoSmart system, and you start swooshing back and forth. And then you have the system that filtrates everything you don't need out, right? So what don't you need in the PRP? That is water. And these are the very small, like salts and solvables that are below 15 kilodalton. So there's a filtration system of 15 kilodalton that gives us the secretome, everything in the blood of value. So this is how you prepare the product. So first you draw some blood, right? You put the PRP tubes into the container, and then, you let the vacuum fill the PRP tubes. And instead of doing one, you take 6, right? So there's going to be 60 milliliters of blood you take from the patient. Imagine the amount of growth factors. Imagine the amount of platelets you have. So 6 of them in the centrifuge, right? It doesn't really matter what kind of tubes you have, what kind of PRP tubes. So they're anticoagulated. These ones have a separation gel. And it doesn't matter what kind of centrifuge, as long as you get the plasma, right? Then you open the box, the ExoSmart, and there is the device. This is the filtration device. This is what it's about. So this device you can load with the plasma. You can see I kind of go back a little bit in order to take out like all the platelets from the plasma. And then 6 of these tubes I take into the 20 milliliter syringes that are supplied with the product, right? Then I have 2 tubes, and in total it's about 30 milliliters what you have in terms of plasma, right? It's about 30 milliliters. And then you can see over here, this is the waste bag, right? This is the waste bag, and you see, maybe it looks a little bit complex when you first see it, but it's actually quite straightforward. You see over there, you see the yellow parts over here. There's a 3-way connector, and you can see where it leads to, where it's open, right? So, for example, this one is now going from the entrance port into the system, right? So you can open that and you can attach the syringe, the 20 ml syringe that contains about 15 ml of plasma. You can connect it to there. And on the other side, you can connect the other one, right? So you can connect them like this, Luer lock connector. It doesn't matter if there's a little bit of air in there, right? That's fine. Then the other one, you also connect it. And then you just start swooshing back and forth. And the plasma goes through these very, very thin tubes that consist of a filter, right? So there's 15 kilodalton pore size, and that pore size lets through the water. So this little bag is going to fill up with water, and that little bag is containing all these non-important things that you don't need for this biological active final secretome. By the way, I'm getting a little hint from my team saying there is a message in the chat for people who are in Benelux, I think, from the distributor. This is a word from the sponsor, so please look in the chat for the word from the sponsor. So as you can see over here, there is now a little bit left. You see, it's been much concentrated, and the bag is full. And then you take off that syringe, and then you can fill these little 1 ml syringes, right? So these little 1 ml syringes, I use Luer lock syringes for that, because you can nicely twist on a 30 gauge needle. And with that, even, in very thick skin, like the scalp of the hair, you can inject it nicely. That is what I'm going to do later in the live demonstration, right? But let's first think about what is inside the secretome. So inside the ExoSmart secretome, you have the EVs, the extracellular vesicles, let's say, AKA the exosomes, right? So, and the interesting thing is that these extracellular vesicles, if you look at how much you take from the blood, the amount of extracellular vesicles is actually much lower than what you finally have in the secretome. How is that possible? Second, you have growth factors, then you have platelets and fibrin, and you have more. But the interesting thing is that you amplify the amount of exosomes, the amount of extracellular vesicles, and that is from about 0.5 to 2 to the times 10 to the power of 12 to up to 3 trillion EVs per milliliter, right? So that is a significant increase in the amount of EVs. And that has to do with the fact that this this filtration device also acts like shear force manipulation of the platelets, where the platelets get activated and actually create more of these very potent regenerative biocues. All right, so this patient is that I prepared the ExoSmart for is receiving this treatment, right? Skin quality improvement of the skin, of the under eyelids. And as you can see, I had some topical anesthesia injected, and you can see a very simple injection, small amounts of product, very superficially injected. And so, very small amounts. I've sped up this video because we're running a little bit low on time. And so after this, you can also go to the upper eyelid, right? So it's lower eyelid, upper eyelid. You can inject it all over the face. You can inject it in the cheeks, in the eyelids. But I think especially for us aesthetic physicians, this is a really interesting field to start with, because we can create volume, we can create skin quality improvement of the cheeks with our BioStim products, but what do we have for the upper and the lower eyelids? Not much, right? So this is a potential product for this area. Now, if you wonder what she looks like after treatment, this is what she looks like after treatment, right? So she has all these little bumps. And of course, we have to tell our patients in advance, bring your most amazing sunglasses to the clinic, because you will look like you've been having a war with some, mosquitoes or something. But this is what she looked like after 4 weeks. After 4 weeks, this is the normal picture. This is the Vectra picture, where you can see, okay, you can really see this skin quality is absolutely improving. And especially if you look at it from the side, right? Let's go back one, because I also wanted to show you the upper eyelid. Do you see the difference in upper eyelids? It's magnificent after 4 weeks. And the interesting thing about this is that after 4 weeks, that's when it's beginning, right? Because what you can expect after 3 to 4 weeks, 3 weeks proliferation, after 4 weeks, it starts. The first clinical signs of improvement are going to be visible. And then maybe 9 to 12 months, another single treatment. So we are done with the 3 treatments of PRP. Also for hair restoration, where we're going to go after this. Only 1 treatment is what it takes to get this kind of result. And this is just the beginning of clinically visible results. I'm extremely impressed, and that's why I wanted to share this new discovery with you guys. So, in the end, my message for you is don't inject products. Inject science into your patients. So that brings us to the last part of this webinar, where I will be going to the treatment room, and while I'm injecting this young man for androgenic alopecia with ExoSmart, I would like to open the Q&A, because during the injections, I can easily answer some questions. All right, so please follow me and let's go to the treatment room. All right, guys. So, as you can see, we're in the treatment room, and here, maybe you can see him. Yes, this Joey is our patient. How are you doing?
Thanks.
Great. So Joey is good. Actually, just before the treatment, my lovely assistant Merel has prepared during the treatment, she's prepared the ExoSmart, and she has put all the secretome into 6 syringes of 1 ml. Thank you 5.5, yes. Very concentrated secretome. And I'm just going to let my hands dry. And so what I have done also to Joey is give him a little bit of anesthesia. Actually, not a little bit. This one left, okay. I gave him a few nerve blocks. So I can tell you exactly what I did. I gave him a supratrochlear, supraorbital, zygomedicotemporal, auriculotemporal, and the greater and lesser occipital nerve blocks. Now, if you want to know about nerve blocks, just find some instruction videos at the UMA Academy website, because that was going to take too much time. We still have a few minutes left, and during those few minutes, I would like to open the floor for the Q&A. I think in the Q&A, there's also some more information about the ExoSmart system, definitely some links from the distributor that you can have a look at. So he has been disinfected, and I'm just going to mark the areas that I'm going to be injecting, right? So you can see over here that there's a little bit of thinning of his hair over here. So I'm just going to give a little mark over here, just in front of the hairline over here. So this is where we make our raise. And, I'm going to go from here, here, here. And, I think maybe doing one side will be enough, depending on the time, because I think we have about 12 minutes left. And so I'm going to start with the first area. So I'm going to re-disinfect, and sometimes it's nice to use a comb. And so you can spread the area in front of you. Can you see this nicely? Yeah, I think so. Okay, so I'm going to inject you. And, I think this is not a 30 gauge needle. Middle, 30 is easier. Actually, it's actually going pretty well. But, it's actually not bad at all. This is a 33, 34 gauge needle. Okay, and here it's getting nice and thick again. So I'm going to go about 1 to 2 centimeters apart. Yeah, actually, I prefer 30 gauge, if you don't mind. And as you can see, I'm very superficial. You see a little bit of blanching when I inject, right? You see here that blanching effect is not because of any adrenaline or any vascular occlusion. It's just because I'm so superficial that I'm compressing the papillary blood vessels, right? So those blood vessels are very superficial in the papillary dermis. And when you create some pressure in the papillary dermis by injecting in the correct papillary layer, then of course you may see a temporary blanching. So Joey, do you feel any pain?
Nothing.
Nothing. Yeah, that's the magic of lidocaine. Whoever invented lidocaine deserves a Nobel Prize. So, are there any questions from the chat, Merel? Can you find out if there are any questions? Or maybe somebody else from the team, Teresa? No questions? How many people are watching? 82. So there should be some questions at least. So the interesting thing is, we recently saw this this webinar where, I can't remember his name now, from Madrid, I think. He, Hernandez or something, I can't remember exactly, but he had amazing results and just one treatment, where normally PRP for androgenic alopecia is at least 3, but more often 5 treatments. And instead of 5, only 1 of these treatments are enough. So that is the left side. So I'm going to go to the second syringe. And actually, you know what? Maybe you can, yeah, thanks. So maybe you can turn a little bit to the left. So like this, maybe we can reorient the camera. So here you can see there's a little bit of thinning here as well. Okay, let's start here. And the danger, if you're very superficial, is that sometimes it comes out. That didn't happen yet. today, but sometimes you have to be ready to move your head away so you can see. And is this also numb, or do you feel completely numb? This is usually quite a sensitive spot. And there's actually, in my KAHA book, my new KAHA book, the second edition, there's a whole chapter including a lot of instruction videos about how to apply these blocks. And I learned from my friend John Leonardo, who is an anesthesiologist, and who wrote the chapter on block anesthesia of the face. Question: does age affect the quality of the Exosmart secretome? That is a very good question. And to be honest, I don't know. But you could imagine that it is possible. But on the other hand, is the quality of the blood affected by age? Of course, blood is young, right? So it arises from stem cells in the bone marrow. And also the platelets, of course, are arising from stem cells in the blood marrow. So in that respect, the age of the patient is something different than the age of the platelets and the age of the blood. So maybe it has some effect, and I think most of the effect is not because of the exosome of the Exosmart, but most of the effect is because of the tissue of the patient, where the tissue has underwent age-related changes. So that means there are more quiescent and dormant fibroblasts. Maybe there's going to be less, like in this case, there's going to be less viable hair follicles, right? So in that case, the age has an effect on how well the Exosmart product is received. One more question. Also quality of PRP based on different PRP systems. Yes, that's correct. So there's different PRP systems and they all claim to be the best. But in the end, you don't need PRP. In the end, you just need the plasma of the patient, right? So that is the PRP plus the PPP, the platelet rich as well as the platelet poor plasma. So in that respect, it really doesn't matter what kind of system you have. So you can use whichever system you like. We also have another system over here. Well, it doesn't matter which one. I don't have to mention the name. But we have two different systems. But these PRP tubes are much cheaper than the PRP tubes of the other system that we also have. And then we have why injection is superficial, not more deep. Hey, that's a nice question after all these videos of deep injection of biostimulatory products. Well, the reason for superficial injection over here, you see this really intradermal. The reason for these superficial injections is that the hair follicles are intradermal. So our target is actually really inside the skin. And so this is where we want the product to be. But if you want to inject your patient with the Exosmart system, maybe in combination with biostimulatory products that you have injected into the retaining ligaments of the face, then yes, absolutely, it might make sense to also inject the Exosmart into the area where you've injected the biostimulatory products as well. All right. So I'm almost done. 1.5 more. Actually, I've skipped this part over here. Oh no, it's actually quite good. Any more questions, Miro? No more questions? Okay, well then I'm just gonna leave you here for a few minutes. All right, I'll come right back to you.
Thank you very much.
Don't walk away, okay?
I try not to fall asleep.
Okay, because I just want to say goodbye to you guys. All right. So I am going to close this session after our live demonstration by saying thank you for joining this UMA Academy webinar. UMA Academy has over 37 international expert faculty, really amazing faculty members. And if you look at these pictures of all these magnificent people, you will probably recognize some of them. Last year in 2025, we received almost 600 doctors from around the world. They're coming from Southeast Asia to Latin America, North America, Middle East, and a lot from Europe, of course, as well. We actually did 35 master courses here at our headquarters. That's actually more than once per 2 weeks, right? And we have a beautiful state-of-the-art training academy with the possibility of hosting large groups. And of course, we are in the middle of the most amazing city in the world, Amsterdam. But maybe there's a little competition between Amsterdam and New York City. So if you prefer New York, then I would gladly like to invite you to come to the event that is hosted by my friend Arthur Swift, who invited me to do a 2-day thing with him. First is on the 3rd of October, where we are going to be talking about the next era of aesthetic medicine. And of course, we're going to be talking about regenerative aesthetics and everything that, you know, we have a full day of lectures and injection videos. And the 5th of October, we're going to be doing a hands-on in New York City. So if you're interested in that, if you're in the North America, if you want to travel to the beautiful Big Apple, please feel free to join us there. So with that, I'd like to thank you very much for your participation. Hold on. It's like the last possible second before I close, there's another question. Lots of hearts coming from the participants and lots of compliments. Well, thank you very much for that great feedback. That really means a lot. Thank you very much for watching and see you at the next one.